one hand, India is the heart attack capital of the world. And in the last 30 years, heart disease has grown by 300%, and deaths from heart disease are rising in India, where in the West, they've actually dropped down by 50%. The second aspect is in the last 15 years, the heart attacks in young people have grown by another 100%. So doubled in the last 15 years. So we're seeing definitely more younger people getting affected from heart disease. And why is that happening? I think we've got to start understanding that it's a worry to us because we are a young country with 60% people less than 40 years of age. And think what's going to happen if heart disease is increasing in them. In the subsequent 15 to 20 years, we're actually going to be inundated. So the real issues are that I think we're seeing a whole lifestyle change. We have actually witnessed the artificialness of firstly, it's a competitive world. The youth is living in a greater competitive world now than it was earlier. It is meeting deadlines. There's workplace competitiveness, there's job competitiveness, there's actually even competitiveness for getting into college and educating yourself and coming out to work and then in the workplace itself. So that has grown hugely. The second aspect is that life has also got very, very, how should we say, stressed. So along with competitors has come in a stressful life, late working hours, unfortunately eating out fast foods, health foods are less consumed. The lack of exercise has become a big issue. Eating healthy foods and eating out has become, an important aspect. And therefore, a whole lifestyle change has happened. The second aspect is that we also are forgetting the influences of perhaps pollution. And it's clearly been demonstrated, unambiguously being demonstrated, that pollution affects heart arteries. The pollutants themselves can cause inflammation of the arteries across the body, can give rise to hypertension, can give rise to even blockages in the heart arteries, can give rise to heart attack. So we're probably not even understanding the influences of pollution as a whole. And who are the people outside? It's the youth which is actually outside because they're on the streets, they've got to go to work, they actually got all over the place. So there's a whole lot of youth, unfortunately, who's facing all this pollution. And smoking, by the way, let's not forget smoking. One of the biggest causes of heart attack has actually gone up, especially in people who work very hard and are very stressed and work night shifts and day shifts. And unfortunately, a whole change in their diurnal lifestyle. It causes a lot of problems. In men, we're still talking about 25 onwards, where regular testing, and a regular testing, I mean a whole spectrum of lipid profiles, looking at lipids, looking at making sure there's not got diabetes, making sure that the other factors are well under control. And once that is put at a level and find that there's no cholesterols or high cholesterols, we do advocate healthy lifestyle and do those tests every 5 years. But for those who have really high cholesterol levels in males, we actually make sure that we actually get them down much earlier in life so as to be able to maintain them for a much longer time, including lifestyle modifications. Those beyond the age of 40, we actually become far more particular in everybody to actually have perhaps those who not got any risk factors and are fine. We'd actually advocate it every 5 years. But those who have risk factors and a family history, we advocate it every year to get a regular checkup done. Now the checkups are in terms of blood tests, they're in terms of an echocardiogram, and they're in terms of an exercise test. So we just do simple tests. These simple tests are available everywhere, but they would pick up heart disease in a vast spectrum of patients. There is one more test which we've now moved on to, which is very important, and that's a CT scan of the heart arteries. Because we must remember that an exercise test picks up blockages only when they've gone beyond 70%. But for these young people who are at risk and have some risk factors, we want to pick up blockages when they're 10%, when they're 20%, when they're 30%, so that we can institute rigorous measures to bring the cholesterols down, to have lifestyle modification, and to stop the blockages at that particular point and prevent them progressing to 70 and 80% when they start causing problems. For that, we use a test called calcium, CT scan. And the CT scan is of two parts. One can just do a calcium scoring, which is a straightforward investigation, takes 5 minutes. And on calcium score, we can pick up the amount of calcium which is deposited in the heart arteries, which in a way correlates with deposition of cholesterol. And we have parameters to tell us whether this is very early or this is advanced. Now, that is a great test. And if there's no calcium scoring is nil, that means no deposition has started in the heart arteries. If we find greater degree of calcification, one can even do a CT angiogram, as we call it, and pick up blockages of 20, 30%. Again, an outward investigation, an external investigation. It's a walk-in, walk-out test of a normal CT scan and gives us 30, 40% blockages. Now, those are the ones, the people who get those are the ones who are at high risk of developing heart disease or have atypical symptoms or have experienced something. Those disease processes, which we say, like diabetes, hypertension, which are all under our control to take care of. And then there are other lifestyle issues which we brought upon ourselves, like smoking, obesity, alcohol, increased over excess alcohol, lack of exercise. So what all these does is firstly control of risk factors. If we control our risk factors better, which means hypertension and diabetes, we actually decrease. We have numerous changes in our body which lead to less deposition of cholesterol in our arteries. The other factors, say exercise, for example, if I give you, actually reverses most of these processes. And that's why we say that 45 minutes of exercise 5 times a week can help tremendously for heart disease. Because with exercise, you lose weight. When you lose weight, you decrease your cholesterol levels at the same time. You actually control your diabetes better. You control hypertension better because exercise drops by 10 millimeters your blood pressure. Your diabetes gets controlled by exercise and expenditure of calories. And at the same time, you bring in positivity and certain endorphins, which are great for your body as a whole. And actually, they don't act as a placebo. They act directly by prevention deposits of cholesterol inside the blood vessels. They can act by decreasing the stress on the heart by causing those very factors which cause dilatation of the arteries. And they also prevent to decrease any direct stress on the arteries of the heart and constriction of arteries of the heart and blood vessels. They don't reverse the phenomenon. What they do is they stop the phenomenon at a particular point and slow the progression of that phenomenon over a period of time, which causes a heart attack. I also want to state that just exercising 5 times a week, because it controls of everything, and by the way, the people who exercise also give up smoking because they believe that this is a bad habit. You won't believe that it can actually drop your risk of having a heart attack by 25%, and there is no tablet which does it to the same extent. So you actually have it in your hands and in your own feet to be able to decrease your chances of a heart attack. We don't need government regulations. We neither need huge prescriptions for it. We neither need all sorts of variety of tablets to take for it. There is just one tablet which exists with us, which decreases our chances the maximum. To prescribe statin randomly across a population as a primary prevention is misuse and overuse of the drug itself. And I think we must remember who it is meant for and why it's meant for. So for secondary prevention, there's no question around it. I mean, when I say secondary prevention, people who started with blockages have had a heart attack, already got some blockages, or the other diabetics who've got a high tendency of developing blockages. No question about statins. We have clear targets defined, what the levels should be. And the more, the worse the number of risk factors, the worse is the chance of developing heart disease. And therefore, the lower is the level of cholesterols that we want to get to. And that definitely improves the chances of survival and decreases the chances of heart attack. So there's no ambiguity around that. The concern is around primary prevention when you actually say, put it in water and distribute it out. Yeah, I don't think that is correct. And very clearly, there's no evidence for that, apart from high-risk populations like diabetics. So in general, when we talk about it, we actually do have to measure the lipid profile, as we call it. We have to define the patient's risk factors. And those who are at higher risk, definitely the lipid profiles do need to be decreased by the use of statins. Statins are a great drug. I think there's the one which has gone around as a lack of information about the primary prevention. Remember the time when we actually had loads of these messages and WhatsApp messages and others being passed around saying statins no use. Now it's proven that statins are of no use, etc. Is not about secondary prevention. And that led to a lot of people misunderstanding that they had heart disease and were taking statins, and statins are a useless drug. So that was meant about exactly what you said in primary prevention. Now, but there's one more factor. There's one more factor that we've got to understand, which is different from the West. So clearly, random prescription of statins should not be done and has no role. The second aspect is then in primary prevention, where does it actually have a role? Which means we haven't got heart disease, but who do we actually give it to? So there are people with very highly elevated cholesterols, which go to LDL cholesterol going to above 170. There are people in whom there's a family history of raised cholesterol, which runs, and that is one other category. There are diabetics, which are the third category. There's also the family history of heart attacks and heart disease is a fourth category. And then finally, we also must remember that, those extreme heart, and India as a whole has anyway 2.5 times more risk than Europeans to develop heart disease. So the risk factor profiling, which is done in United States, we must remember that we're 2.5 times more. So our threshold for giving statins cannot be the same as the ones in United States. We have a lower threshold. We have people with raised triglycerides, central obesity, and glucose intolerance, syndrome X situation in this country, where LDL cholesterols are not that high, but triglycerides are much higher. And in those, if the lifestyle modification does not get their lipid profile under control, again, that is a role for statins because those are high-risk individuals in our country. So we have a lesser threshold in the West of prescription of statin for primary prevention because we know our risk is 2.5 times higher, but it by no means is it a random prescription. It is a very specific prescription with clear-cut guidelines and demarcated target levels.